Hello, everyone. Welcome back to Fresh Dental Shadowing. Today we have Dr. Siama Muhammad for our virtual session. So she will start her session now.
Hi, everybody. Thanks so much for joining. Just want to confirm you can see my screen. Okay, great. My name is Dr. Siama Muhammad. I have a practice out in Brooklyn, New York. And I am really happy to be here today to share a little bit about my journey into dentistry and how I practice what my expertise is in. So just a brief outline of what's going to be discussed today. So I'll give you kind of like a background of how I came into dentistry. We'll talk about what cosmetic dentistry is and how I practice it. We'll talk about airway dentistry, which is exciting and sort of a more up and coming track in dentistry. I'll talk about my typical workday, typical things I see in practice, typical patient complaints, and like common procedures that we do in my practice, and some instruments and tools that we use that I'll try to kind of focus on the cosmetic and airway tools that we use, and just general topics and vocabulary. And then I have two cases for you to just kind of delve into to see a case from beginning to end. So why I wanted to become a dentist, my sort of education background. My mom was a physician. I loved like she was a family GP physician, and I loved her clinic, that she actually ran a clinic, and I loved how she interacted with her team members, and I liked going there and seeing how things were run, and just like also following her to the hospital, and it was just fun. Like you could go to the cafeteria and get food, and you take care of people. And some people tell me that they don't like the hospital. I actually have like really positive memories of being in a hospital as a child of a physician, because I didn't have to see all the the bad stuff that happens to patients. But so that's kind of how I got interested in the healthcare field. There's a lot of pros of choosing dentistry over, becoming a physician, in terms of like your lifestyle and your ability to have a private practice maybe more easily or readily than a physician. And the capability of doing sort of, more specialized things like cosmetic dentistry or different specialties, that can be very rewarding. I went to high school in Chelmsford, Massachusetts. My family still lives there. I actually applied right out of high school to the accelerated dental programs. So they have a few, I don't know if they still exist. This was, by the way, 15 years ago. So I went through the Boston University 7-year accelerated dental program. There's also one that I applied to that was out in upstate New York with the Rensselaer Polytechnic Institute that was affiliated with UPenn, which is a 6-year program, because I kind of knew what I wanted to do. I liked the aspect of being in the healthcare profession, but also being able to do something with my hands. And, I think a lot of dentists say this, that you get to, it is really a mix of art and science. So I went to undergrad and grad school, both at BU in that combined program. I graduated in 2005. In Massachusetts at the time, I am not sure if it's still the same, but wasn't required to do a GPR or residency. And I was just, excited, and I needed to go to work right away and financially. So I did go to work right away. I had the opportunity to be a part of a really busy Medicaid office. So I have, I kind of have been through all different types of work settings. I've been in a very high volume Medicaid office. That was for 2 years, where I gained a ton of experience with all phases of dentistry, lots of extractions, a lot of root canals, and just, regular restorative dentistry too. I also worked for corporate dentistry with Cool Smiles, which was they focus on kids. So that was my corporate experience. And then I also worked in smaller private practice when I moved to New York. But I never really was happy with being an associate. I always felt like for me and the practices that I got a job at, and there were other practices that I didn't get a job at, to be completely frank. And so I just was never happy with the level of customer service that those practices I worked at provided. And I felt it was pretty hard to find a position in a good quality private practice setting. So I just decided to open my own. I was like, I didn't know that I could. And then I found out that banks actually dentists actually get loans pretty easily from the bank. And once I found that out, it was like a no brainer for me. I was like, I need to open my own practice. I have a very particular way that I want to practice. Is very customer service oriented. So that's what I did, actually almost 9 years ago now. So cosmetic dentistry, I do practice general dentistry as well. So I'll start with what that means in my practice. For me, that means starting with meeting the patient, the person, before you even get to the specific area that we're going to look at, getting to know the person. And then a comprehensive exam and treatment plan, and I'll go over what that means for the way that I do it for my patients. General dentistry, general definition is that includes all phases of treatment, from prevention to cleanings to fillings to root canals to crowns. So it's where patients go regularly for routine dental work that doesn't require a specialist. And, a lot of general dentists also do root canals and more complex things, implants. So as a general dentist, of course, you can do all of that as well. So the goal is in general practice, is to get patients into maintainable health and returning regularly for re-care, hygiene, and checkups. So patient that's come in for the first time and we've gone over their exam and diagnosed and made a treatment plan. Our goal is to get through that treatment plan, and then eventually they don't really need much except maintenance. And, obviously things happen like broken teeth and some uncontrollable things. But yes, that's kind of like what our practice looks like. We have, and most general dentistry practices look like. Cosmetic dentistry, I'll tell you my personal definition of this is establishing the proper arch form and aesthetic result through addressing tooth and jaw position as well as tooth appearance. So kind of like bottom line for that is there's a reason that teeth end up looking a certain way. So for example, this case on this lower right side, these two teeth, the patient was really unhappy with the way that they looked. And, we could have just fixed them with some crowns like we did, ultimately. But I always, because of the kind of practice that I'm in, where it is really a neighborhood feel, and I see patients, long-term patients stay in my practice, I want to find out why this happened in the first place so I can address that. And so it doesn't happen again to the really nice crowns that we made. So that has to do with, jaw position and tooth wear and why we wear our teeth and why we grind our teeth. And that gets into a little bit of airway. So airway is like the ultimate answer to why things happen in the mouth. And I hope you guys in dental school eventually start learning more about that, because we didn't learn anything about it in my day in dental school 15 years ago. So airway dentistry is a practice of dentistry that includes the knowledge of how, this is my definition, I just made it up to update this presentation because I put a poll out and you guys wanted to hear about airway. So the practice of dentistry that includes the knowledge of how the jaws, teeth, tongue, and surrounding muscles and tissue impact the airway. Airway in turn affects breathing and sleep, and an airway dentist can work with a multidisciplinary team to improve them. So this is actually my 3D scan, a CBCT, a cone beam CT. So it's similar to a CAT scan, but it's much less radiation, and it's just focused on either a specific area of the jaw, or for airway we do the upper and lower jaws, and actually part of the skull, the upper skull. So generally, so you can see here, this is actually the maxilla, and this is the maxillary teeth, and this is the mandible, and this is the part of, in this slice of the CBCT, this is the part of the mandible you can see. And this is the airway, this dark area, and it actually should look like this, but you can actually use the software to measure this and see how wide it is. And then this is the spine in the back. So the jaws, depending on what position they're in, how wide they are, how narrow they are, how far forward they are, back they are, they can directly affect the size of the airway. And that affects sleep, and that affects breathing. And if you start reading about this and taking courses in it, you will see this in everyday practice. It's not, it's it is something I see every day in practice, and that's why I'm passionate about it. And again, it really gets to answering those questions of why did this tooth break on a piece of corn or on a piece of toast? It's probably because your jaws are in a certain way, and the way that you grind your teeth, that tooth, or the way you just use your teeth for function, normal function. There's answers to those questions. So you just have to dig deep. So a little bit more about my practice. It's in a really lovely neighborhood called Park Slope, Brooklyn. It's got this small neighborhood feel. I always call it like Sesame Street, and because I have tons of stories where patients don't know that their friend goes there, and then they meet in the waiting room, or they meet in the Uber going home, and they're like, "Oh, you're going to Dr. Muhammad. We're coming from her." So it's really nice. I'm very lucky to have a practice in such a wonderful neighborhood. My typical day, I have 3 kids, and I I do school drop off, but the good thing about having your own office is you get to set your hours. And so I get to my office around 8:30, and we meet with the team, and we go over the schedule. And I see patients on Monday through Thursday, 9 a.m. to 5 p.m. So most dentists, full time for them is considered 4 days a week, 32 hours. And hopefully maybe one day I'll be able to do 3 days a week, but not yet. Fridays, we actually have an associate pediatric dentist working in the practice now, which has been great. We have a lot of kids in the neighborhood that come to us as well. So I reserve that time. There's a lot of business things, that business management and development and team management that needs time, and it needs really a whole day, and maybe even more than a day per week to really have a handle on that. So I try to reserve that for Fridays. We are always communication so important, before or after patients, or we try to do it in the morning huddle. We have 3 operatories and 2 hygienists. So I actually right now only work out of 1 room, which is hard because usually you should have 2 rooms that you can sort of flank and work out of. And then I get called for hygiene checks during procedures. So I have a patient in my room, and there's 2 other patients that the hygienists are taking care of in the other rooms, and then I'm expected to do their exam. So it does get a lot. I know my hygienists are really patient with me, and I do get, it's a lot. You feel like you're a chicken with your head cut off sometimes, but it's worth it. And my team really helps me be able to do everything that I need to do. So we usually have actually around 1 to 2 new patients every day, and usually at least 1 emergency, usually a new patient emergency that happens every day. Some just general advice as we delve in for prospective dental students. It's a great field. Dentistry is a great field. It's always, there's never a time where you feel like, well, I think some people are happy just, staying in the same place, but there's always room for growth, which is, I love that. There's always, it's the practice of dentistry. It's like you're always learning and building on your skills and your knowledge. And take your time deciding, doing things like this, dental shadowing or getting to know a dentist, or, is really important. I did in high school, it wasn't even shadowing. They wouldn't let me shadow. It was just like free. I was a free worker for the local dental office, and I loved it. I loved the way that I just loved the office environment for some reason. It's something that I enjoy. And so see if it's something you enjoy. If you can, go into a dental office, or talk to a dentist, or talk to a hygienist, or talk to an assistant. Those team members are also super valuable, and they can provide lots of insight. And I'm sure there's some dentists and team members are going to say they don't like it, but try it out, give it a try. For me, the most important part of dentistry has everything to do with relationships and people. My type of practice that I had the vision for, the reason I opened it was because I do really value customer service, and I'm not in that type of practice where I just want people coming in and leaving. I actually enjoy seeing the whole family, from grandmother to mother to daughter. And we see generations, and we see grown siblings, and it's nice. I like that. So, and you can practice in a different way, but this is what it means to me. I think in general, if you love to interact with people and get to know them over time, like, you're going to be a super successful dentist. One of the ones that I know that are happy doing dentistry are the ones that actually like to interact with people. The most important thing is having a good business sense and a sustainable lifestyle. It can get stressful because we have a big amount of overhead in dental. We have expensive equipment, we have expensive team. You have to pay your team, and if your lifestyle is lavish, you're going to have, it's difficult to get to that point. For me, it is. It's not easy for me to sell dentistry. So, I just value doing things without selling, and just actually doing things that the patient values. So that's just a side thing. You have to kind of do your ROI and see if this is going to be the right ROI for you. The dental skills and clinical expertise come with practice, patience, and continued learning. So what I'm saying there is that, you're not going to be perfect the first year out of school, and don't expect yourself to be, and just have the confidence, and it will come. It will come if you keep at it. So some typical things that we see in practice every day. So people that just want a cleaning, which is great. And then we have the other side of the spectrum, people that, are haven't been to the dentist in sometimes 10 years or more. And we get a good amount of people that haven't been to the dentist in a long time because I think we have like a reputation of being non-judgmental, which is good. So it does allow us to have people come in that would previously feel like ashamed to go. A lot of people come in saying they broke their tooth or their tooth chipped. Toothaches are a big thing that we deal with regularly. Sensitivity is definitely something that we see. Bleeding gums, jaw pain, teeth grinding for sure. Post-pandemic or during pandemic, that's definitely on the uprise. My teeth are yellow, my teeth are crooked, and my teeth are worn down. So what I usually say is in practice, we do still see a lot of cavities, a lot of teeth that need to be crowned, a lot of gum disease. And those are acute problems that we can treat right away. And those are like what we really, the bread and butter that we learn in dental school. But there's also the more chronic things that we see that involve more like teeth randomly breaking, tooth sensitivity, grinding teeth, worn teeth. So those are like more chronic problems that I think traditionally we just watched those things, but now there are actual treatments that you can get to the root cause of why those types of things are happening. So the common procedures, comprehensive exam is so important. So we in the way that I have learned and added and layered onto my exam, as I do examine joint, muscles, soft tissues, and we do a full periodontal probing, and we look at the airway. And I'll show you some pictures of that, the teeth, and then how the teeth come together in a bite. So we use our iTero scanner for a lot of cases. And then after you do a comprehensive examination, your software can help you with this, but you can put it together into a treatment plan that has cost estimates. And for more complex cases, we do bring those patients back so that we can talk to them in like full detail so they're comfortable. If they have any questions, we use a lot of, props in the office, and I have my own like spiels about things, and I use my hand to show them, this is your crown and my arm is like your root. So you'll develop your own sort of ways to explain things. And that's part of treatment planning. And then, other common procedures are just overseeing. I did a lot of my own prophies, which are cleanings and scalings. When I first opened my practice, I opened with 0 patients. So I didn't have hygienists in the beginning. I did that all on my own. It's a great way to gain insight into the oral cavity by doing your own cleanings and scalings. But now I thankfully don't have to do that anymore because my hygienists do it and I can focus on things that only I can do. Fillings, crowns, root canals, those are all very like normal things that general dentists do. Implants, I did a continuum at 99 hours of continuing education at Columbia University back in 2013. So I do place some implants. Invisalign and expansion. So again, this has to do with jaw position and tooth alignment. What we're finding is that a lot of people have, had braces, but they're relapsed because they didn't wear their retainers. And it's not just cosmetic. It really, that's where when you start looking at things more closely and you start seeing patterns, like this tooth chipped because it's out of line and it's touching the top tooth too hard. That's the only tooth that's been touching for so long. So Invisalign for me isn't cosmetic in my practice. It's really functional. Like we get the teeth to the proper position where they have a proper bite relationship and the bite is even and the teeth are standing upright instead of leaning inwards, which causes excessive forces and interferences. So bite analysis is also a really, it's a common thing that we do because again, we see bite discrepancies as the cause for a lot of issues. We do bondings, composite bondings, which are a great, more affordable way to do cosmetic work on teeth that are worn, or just teeth that somebody fell and they broke their tooth. So it's a great way to build up broken tooth structure when applicable. Veneers, we love doing veneers. It's really fun, and it's like that wow factor. Takes a lot of work we have to take photos and we have to see what the patient wants. We usually block off like a whole day for that case, because it does involve a lot of time and effort and, work in the patient's mouth as well. Gingivectomies are another procedure, which is removal of gum tissue. Sometimes that is purely cosmetic. And tooth whitening, which definitely is fully cosmetic work. So some of my favorite things to use in the office are, I put this in here because it's kind of like a pet peeve of mine when, you go to a doctor or someone, and they don't even say, hi, how are you? Like, that's my biggest thing. I always say, hi, how are you? And then I stop, because it's like we're human. Like, we need to make that connection first before we move on and start, poking your face. We need to get to know each other. So that's a really important tool. And I think that is like the first tool that you should, just your connection with the patient. And then you get their subjective patient experience, right? That's important, because we have to address patients' chief complaints. You get history. So my assistant actually is really great. She does basically all of this for me. And then when I come into the room, she gives me a debriefing of what she's gathered. So that's very, very important, kind of getting some background. We use a periodontal probe. We were heavily trained in this at Boston University to check the 6 points around each tooth that shows how well attached the root of the tooth is to the gums and to the bone, right? So that's really important. Diagnostic casts are, we could do it digitally now with the scanner. So it's basically just like a mold of your teeth and the surrounding gums. That is great knowledge for the patient case, depending on what case you're doing. We do photography. I got this, I took some courses with Spear Education, and they recommended this PhotoMed camera that's like already set up for dentists, so I don't have to do too much with it. I just pretty much point and adjust this little gauge and then shoot. And we do digital mock-ups as well. So I use this app called Pixelmator, where I can actually like take a picture of somebody's smile, upload it to the app, and I can use use that app to make the teeth longer, or make the teeth more symmetric, or close gaps, or see what things would look like within their lips and tongue. We also have a laser, and we have an articulator as well, which is, in dental school, it's the much dreaded instrument, but it's you have two models, and then you put them together, and it's like on a mock jaw. So you can see how the jaw kind of slides, and what happens to the teeth when that the model jaw slides forward and backward and side to side. So it's an important tool, especially if you're doing a lot of reconstructive work or a lot of veneers, for example. You want to know what's going to happen to those veneers when the jaw moves around. Some newer technology, I've been talking about the iTero scanner. We use it to do the models instead of, the goopy stuff that you had when you were at the orthodontist. So patients love that. It's, then you see the models on a big screen right in front of you. And then we just did recently get a CBCT, which is a cone beam CT. It's a 3D X-ray, basically, where you can move the models around, or you can look at different slices of the airway, or of tooth roots, or of the TMJ joint as well. So some terms in airway dentistry that we use every day in my practice during an examination, and also during we do a workup for airway treatment, and we also do this during there. So the Malampati score is when you look at somebody's, basically their, what in lay terms is throat. It's the opening in the back of the mouth to the airway, right? So you have the uvula here, and it's really supposed to be just opening your mouth without saying ah, like, and what you see back there when the patient does not say ah. So this is a good Malampati score. This is like a Malampati 1. I think the patient was saying ah here though. So when you don't see, you see this, I call it the McDonald's arch. When you see that McDonald's arch and like a good space behind it, that is a good Malampati. That means that you can see the opening to the airway. Most times when you look back there, people have this, you can't see this. You can't see this at all. All you see is the tongue basically all the way up here. So that is Malampati class 4. That's, you know, everything is kind of constricted. The tongue kind of falls back and is potentially could obstruct your airway. Tonsil grade, when you look back here, these are the pillars of the soft palate. And tonsils, if you see this bulbous tissue coming out here, that would be tonsil grade 3 or 4. If you see this, you don't really see the tonsils very much. Maybe you see a little bit poking out. That's tonsil grade 2. So those are also tissues that obstruct the airway. And then we do, you know, a muscle exam as well. And that's part of airway. So a lot of people, when you tell them to clench together, to clench their teeth together, these muscles will, like, you'll feel them kind of popping out, the temples and the masseters. And if they do that, that means they're clenching and grinding either during the day or during the night. And then you ask yourself, why do we clench and grind? Most people say stress, but it's a chicken and egg thing. We may be more stressed. Obviously, our lives as humans these days are just stressful. But what can we do to, what else is causing that clenching and grinding? And some of the newer information that's coming out is pointing to being able, we clench and grind, especially during sleep, to be able to breathe better. Our jaw is waking ourselves up or moving forward so that we open up our airways. It's the body's defense mechanism. So those are all names of muscles. Masseters, temporalis, and pterygoid is on the inside. It's the inner sling of this musculature right here. So some more general dentistry terms. So like I said, I did some training with Spear Education. So it's, I use facially generated treatment planning. So that what that means is you look at the face and you see where the teeth are in the face, instead of just, you know, looking here, like just at the teeth, where are the teeth supposed to be in the face? And that means like in the profile, as well as here, like do the teeth fill the corners of the mouth? And we'll go through a case to kind of look at that. So it's kind of like when you're in dental school, you learn how to set a denture. So a quiz question, what are the first 2 teeth that you set on a denture? They're actually the front 2 teeth that you set. Because why? Because you use the face to tell you the only teeth that you know where they're supposed to go exactly is the front 2 teeth. They're supposed to go right in symmetric in the midline of the nose and the lips, right? So then once you have those, then you can put everything else in place. So that's the idea, is like, you know where the teeth are supposed to go by looking at the face. And then everything else function is how, so this picture here, we, again, in my practice, and you can see they have the Invisalign attachments on. This was a picture we took before the first day that they got the attachments, to see how their bite was. So their bite, the reason we did this Invisalign treatments, their bite was really, really heavy and was causing some fractures in some of the teeth. And so that's function. That's, are your teeth functioning? Are they breaking? What's causing, what's dysfunctional about the bite that might be causing issues? And then structure is, you're missing tooth structure when you grind your teeth away. And then again, why did that happen? And biology, there's so much biology that we have to think about in terms of the gums, where the gums are supposed to be, are the gums healthy, and what's going on inside the tooth with the pulp. So all of that, more like more biology, more biological aspects of what's happening with the teeth and the surrounding tissues. So this case is from a while ago. So this is before I had my PhotoMed camera, my DSLR camera. So the patient's chief complaint was that my teeth are worn down and I don't like my smile. So again, we looked at facially generated treatment plan. We looked at her teeth, and I could have just put veneers on as is, but when I started looking really closely, this tooth was really much more worn down than this tooth. And as it had worn down, it actually started shifting out of the gum line and coming down. So the better way to do is kind of like to put the teeth where they're supposed to be. And I'll show you that in the next picture. But so what should the teeth look like? Where should they be in space? Where should they be in the patient's space? So again, we could just slap on veneers here, but what about putting them back where they're supposed to be? Because as teeth wear and tear, they actually shift and try to meet each other. And what about how much tooth structure do they display already? So she actually displays a nice amount of tooth structure. Is her midline centered? Do her teeth follow the curve of her lower lip? So you can see her lips are actually not really symmetric. So this would be, as we wouldn't make the teeth kind of like go down where her lip goes down. But in general, you want a nice curve to the smile. And then we draw a line here and we see if it's symmetric with her eyes, which of course her eyes are not in this picture, but there's all kinds of leveling. That's why it is actually really important to get a full face picture to see where the teeth go in relation to the pupils and the nose and the midline and everything. So this is what we actually did for her. We first, we looked at the buccal corridor, which is, buccal means cheek and corridor means corridor, but the space between where the teeth are and the corner of the lips, that's the buccal corridor. So you can see dark space here and dark space here. So that's one really important question that we ask. Does the smile fill the buccal corridor? Because we could just do, again, 4 veneers and maybe she would be happy, but if she really wants that full aesthetic result, we're gonna talk to her about her options. So this is after we did Invisalign. We actually moved this tooth back up. You can see the difference of how far down it was here, and then we moved it up and we actually really widened her arch, which back here when I was doing this case, I didn't know much about airway dentistry at all, but now I do know that expanding is actually the way to do orthodontics. Is you always want to do expansive orthodontics. You never want to be squeezing things together because that's restricting the volume of your oral cavity, and then therefore it's restricting the airway volume. There are different options. Do we move the teeth? Do we move the gums? And do we do something with the bite? Do we care about the bite? So are there, and in biology, are there any actual gum, acute issues with the gum or the roots of the teeth or any biological aspect? So in this case, she was fine. We did orthodontics first with Invisalign to broaden her arch form, to fill in that smile, and to put the teeth back where they were originally. Her tooth was a full tooth at some point. She's older lady in her 70s, actually. So her tooth was a full tooth like this, except it had tooth structure. And then for some reason, something happened with her function and her arch form that she wore this tooth down more than the other. So again, we set her up, and then the next slide will show what we did for her long term. So then we did the veneers and we filled in all of the space there, and she's super happy. She's obviously still a member of our practice, and she's a great lady too. And that's one thing I said last time I did a presentation. I was like, do your, like, don't do, have good patience and like build that relationship, and like, you know, doing this kind of dentistry on somebody you actually care for is even more rewarding. So it's great. So this is case number 2. So this patient's also lovely. He's been in my office since I pretty much started. And so he had this tooth. It's a front tooth number 9, I believe. And this dark area right here is something called internal resorption, which we're seeing quite a bit. And I think it's related to clenching or grinding. Nobody really knows why this happens, where it's basically your tooth is eating itself from the pulp out. So something happens where the tooth is like, doesn't like it. It's like an autoimmune thing that happens from the inside out. It's called internal resorption. So, you know, we had been watching it for a while, and then this is 2014, this is 2018, and it actually eventually just ate through the whole root of the tooth. And then we needed to extract the tooth. So we actually referred him. We work really closely with some really great specialists in the area. And so we coordinated, and I made this bright white, and the x-ray looks bright white, zirconia cantilever temporary bridge, so that he could have a front tooth while, and I'll show you a picture, while he was going through this. He had to have extensive grafting in the area. You see these little white screws. These are little tack screws that the periodontist put in to hold the graft in place. So we again coordinated so that I made this cantilever while he was getting the work with the periodontist. So again, this is what it looked like with the bone grafting the periodontist put in. And then this is what the implant looks like that the periodontist put in. And you can see here, this is how the tooth looks without the cantilever bridge. And this is actually the final crown that we put in. It was an all ceramic crown. And then we took the final impression the same day for the implant supported crown. So this is what his tooth looked like, the one with the internal resorption before. This is like a picture from way back with our intraoral camera, not a good quality picture. And then this is what the cantilever bridge looked like. So this is the natural tooth number 8, and this is the extracted tooth, so empty space. And so this is what we decided to do so that he could have teeth while he was undergoing that implant grafting. And again, without the cantilever, this is what it looked like with the implant healing abutment. And then this is where we prepped this a little bit more, and we took an impression. And this is his final, this is, I think this is with the cantilever in, and then this is his final result. And then this patient just came back recently. Well, he comes back. He's a great patient too. He always returns for recare. And we have been talking about his bite for a long time, because he has this open bite where he has a space between his front teeth. And when you have teeth that don't match together, usually it's the front teeth that have an open bite. So I have seen posterior open bites too. But when the front teeth don't touch together and the back teeth are the only ones that touch together when you're biting, what happens is that your teeth never get used up here. And there's actually a very intricate balance between your teeth in the front being used and your back teeth. The teeth in the front are supposed to take all of the sliding movements. Like when you slide your jaw forward, side to side, they're designed for that. They're the longer roots, and they're designed for that, to take those sliding forces. The back teeth are really not designed for any side to side sliding forces. They're only designed for vertical. This is all the back teeth are supposed to do. This. If they start rubbing together like this, that's when you get toothaches that are unexplained. They're toothaches in teeth that do not have cavities. You get fracture lines in teeth that never got, the patient never bit into an olive pit. It's just from regular food. They get fracture lines. So that's why, he actually has a tooth that's been bothering him, and there's no cavity in it. We've sent him to a specialist. There's nothing wrong with the tooth, except that it's been pounded on for years and years because his front teeth never came together. So those back teeth have been rubbing chronically. So he's going to actually start Invisalign pretty soon. And that's, also some of the clues that you see is like, look how his canines look how sharp they are. And they've never been used. And those canines are such important cornerstones of the bite and of the mouth. You need to use your canines to have, function and longevity in your mouth. If you're not using them, things are going to start breaking down. So getting to the end of the presentation, my advice to our future dentists is it's the practice of dentistry. You learn every day and you practice every day. I think people who go into this field are naturally perfectionists, and we really, and that's a good thing. You want to be a perfectionist in this field, but I've had moments in my life. I was telling these guys, like today was actually a tough day, where we're really rough on ourselves, but try your best, be there, be present for your patients, and do everything in your power. And, everything beyond that is not in your control. And stuff happens that you're going to be upset about, but, it's a practice of dentistry, and not everything's going to be perfect all the time. There are reasons that the teeth and mouth got to the current state in the first place. So that's what I love, to be a detective and find out why this happened in the first place, so that my patients can have a result that's going to last a really long time. Think outside the box and get to the root cause. There's no natural system where tooth decay occurs. That's Stephen Lin, Dr. Stephen Lin. Follow him. He's great. No other animals have tooth decay unless, you're a domesticated animal like we are, our cats and dogs. Our ancestors didn't have tooth decay. It has to do with, what we put our bodies through in our modern society. And you can't brush and floss your way out of a bad diet. That's another one. It has to do, again, with our potential as to have a healthy mouth, and all of the things in modern society that affect that. Yeah, that's it. Thank you. I'd love to take your
Thank
questions.
you so much. Thank you so much. We can start with a few questions. So how do you think being part of a accelerated program was different from doing an undergrad course and then then going to a dental school?
Yeah. It was hard because so the undergrad portion was only 3 years. Not hard in terms of academics, but hard in terms of I actually, as you do in undergrad, you get your group of friends, and you have, undergrad is mostly about becoming a person, coming into yourself, finding your people, and really developing your sense of who you are. And it was tough for me to move on after year 3 when my friends were seniors and, doing all the senior stuff. So that was one thing that I missed out on, but I don't regret it. I still was in Boston. So I was distracted in first year dental school for sure because of that, because, I wanted to party with them as seniors, but I was a first year in dental school at the same time. So I think I could have, if you're not in a hurry, just do the traditional route. I think I was in a hurry because that's just how my family encouraged me to do it, my parents. And I needed to be financially independent like sooner than other people. So if that doesn't bother you, do it. And I think it's great to also save a year of undergrad school tuition. So there's a balance there, but yeah.
So how do you maintain your work-life balance between being a full-time dentist and your normal life?
Yeah, it's hard. I think it's good to have a practice near like my family. So like my kid's school is actually down the block. So he walks to my office now that he's in 5th grade. He can walk to my office, and again, having your own hours, and I think you can do this somewhat as an associate as well. You can kind of build your schedule. You can work one day or you can work 2 days. I mean, everybody has different financial things that they need to take care of. So you might have to work more days, but like kind of keeping your family life not too far away physically, distance wise is one tip. And now we have software that like in the beginning, and even now, I still work from home, like doing chart notes or looking at x-rays or looking at a patient. I take emergency calls at home. But yeah, it's not easy for sure. It's a lot of work, but my personality and the way that I couldn't just be an associate. I had to do this, and I think it works for me, but it doesn't work for everybody. So yeah.
What's your favorite thing about being a cosmetic dentist?
That like wow factor of when a patient like sees their new smile, or they come back and they're like, so and so said that my teeth look amazing, and you really change their life. You really do, because even with the masks and everything, it's huge to be able to smile fully. I think that's an underrated thing, to be able to like fully smile. Like when I see people, even there's like some really famous people that don't smile fully, and I'm always like, there's something they're holding back, like smile. So I think just that being able to really influence somebody. And now I think people especially with more Zoom, people are really into like how their teeth look. Like more people want to do whitening, more people want to do cosmetic work. So it's like it's your face, it's not just cosmetic. It really is a sign of your vitality, having a good full smile, and that's part of your health.
How do you like go about the treatment plan for a patient? Because it's like different from every patient to patient. So is there a set plan, or it just changes with the patient?
It changes, definitely. We do a lot of individual, like we don't do one size fit all. That comprehensive exam, like going from here to the muscles to the quick airway screening that we do, and then doing a full periodontal charting and actually charting every single tooth. And then also, again, like the patient perspective. So some patients who their chief complaint is, I just want a cleaning. I'm not going to say, oh, I'll point out everything that I see. Like, I see your teeth are worn. I see that you have recession. I see that your gums are bleeding. And this is what I recommend. And this is what's going to happen if you don't do it. Like, and sometimes I'm very honest, like with tooth wear and tear, nothing's going to happen tomorrow. This is going to happen when you're 70. And then, because I do have 70-year-old patients that now they have to deal with all these teeth that are worn down. So yeah, it's definitely different for every patient. But we do it in a very systematic way, where we go through all of the systems, and then we sort of tell the patient everything we see, but we don't ever, it is individualized depending on what the patient wants and what their chief complaint is. And finances play a big role in that too, patient finances. And we really try to work with each individual. Yeah.
I think that's all the questions we have. Thank you so much for being here with
You're
us
welcome.
and so helpful for us.
Thank you guys. Take
Thank
care. Have a
you.
good night.
You too. Thank you.